Hello, everybody, and welcome to Intermountain Grand Rounds. I'm your host today, Paul Krakowitz, and it's a real honor for me to bring forward another edition of our Wellbeing series here in our Intermountain Grand Rounds. And this one, as always, is timely, and I expect is going to be a pretty deep conversation. You know, Healthcare and burnout and resiliency, these have been issues that have been going on for a long, long time. They way predate the pandemic. Then the pandemic hit, and we all became very singularly focused on this virus. And then very early on, we all got punched in the gut when we heard about the national news about Dr. Lorna Breen dying by suicide. And it woke us all up. Uh, the reaction for a lot of us was to put our heads back down and realize we have to deal with the virus. And at some point, we had to come back up and start talking about that, which fortunately we have. I'm just really pleased to see who's on our panel and to have this very deep conversation about what's super necessary, which is what the outcomes can be when we allow burnout to go too far. We've had a Grand Round series on leading through ambiguity with optimism, and that is a real part of this, but I think there's going to just be so much more that we're going to learn today. So with that, I'd like to turn this over to Dr. Pendo. I would give an introduction to her, but she's been on many times before and she needs no introduction. So with this, I'll hand it over to you, Dr. Pendo.
Great. Thank you so much, Paul. And thank you everyone for joining our Wellbeing series, Thriving in Medicine today. We are being agile in our audio-visual skills. I am on my phone. Dr. Katie Thomas will be running the slides. And today we are going to talk about how the pandemic has impacted us and our lives, and as we think about our mental well-being. For those of you who may not know, I have responsibility at Intermountain for physician and APP experience and well-being, and I'm pleased to have as our guest Corey Feist, who is a healthcare executive and is a co-founder of the Dr. Lorna Breen Heroes Foundation and Chief Executive Officer of the University of Virginia Physicians Group. Corey and I met in January at a burnout symposium, and I was so pleased that I was able to meet you, as I have been following your work and the work of the foundation since its inception. And as we were able to chat about your experience losing your sister-in-law, I was able to speak about the experience of losing my son to suicide. I felt like we really connected on that much deeper level of having gone through an incredibly painful and emotional experience, and both of us stepping up to make things better. So we are so pleased, Corey, that you are here today and are taking the time to join us. We're looking forward to hearing from you and learning from you. We also have on our panel Dr. Mason Turner, and Mason is the Senior Medical Director for Behavioral Health at Intermountain Healthcare. Mason right now is in Hawaii with his family. He is a psychiatrist and addiction medicine physician with over 20 years of clinical experience. And he has been focused. We have so appreciated his expertise as we work to coordinate, align, partner to improve the well-being and mental health of clinicians and caregivers throughout and across Intermountain. Go to the next slide, Katie. So as we began this well-being series, I really wanted to focus on what can our best days in medicine look like, and the Thriving in Medicine Wellbeing series was created, thinking about how we can get back to happiness, meaningfulness, self-worth, self-efficacy, satisfaction at work and at home. And the closer alignment of our two lives is really one of the goals of our work today. Go to the next slide. So many of you know, I like to start with an experience story. And some of you have seen the slide on the upper left, which is at the wedding of our oldest son in July of 2019. And the story I'm going to share about this slide, with my mother in the middle, my daughter in the striped jumpsuit and the big smile, and my daughter-in-law on the other side, was it was a wonderful day, and I was working. And I thought that that was normal. I thought that that was what was expected of me. And I didn't consider saying no, even though I got the eye roll from my family. And then COVID happened. And, that really did change everything in terms of how we showed up to work, a lot of uncertainty, fear, a lot of grief and sadness as our patients passed, and how we supported our caregivers teams, patients, families, and each other. And then we are living in this world with external factors that are so out of our control. It seems, just stay on that last slide for a second, thinking about our political climate, climate change, the difficult conversations we had around masking, vaccines, and at the same time, we were all living our lives. We had babies and grandbabies be born. Dr. Tamara Moore's Todd had 2 COVID babies born during this time. Some of us lost parents. Some of us had to step in and care for aging or elderly parents. Some of us were homeschooling. Some of us dealt with our own mental health and physical health issues. So nothing seemed to stop. Go to the next slide. And as we really stopped for a moment to consider, we had to be honest with ourselves that pre-COVID, pre-pandemic, we weren't really doing as well as we might have led ourselves to believe, that we were living in chaos. We weren't honest about our experience. We were afraid to raise our hands and say, I need help. And we were afraid to say, I'm not going to work. My son's getting married. I'm going to be present in that moment. So as we think about all of this in the context of our conversation today, what are the things that we need to do differently? What do we want to think about that is going to be necessary to become our best selves at work and at home? As we think about those who have died over these past 2 years, whether through a medical condition, whether through COVID, whether by suicide, all of this has really compounded our grief and intensified our emotions. So go to the next slide, Katie. So as we think about our goals today, I would like to take time to remember and acknowledge what we've experienced. I want to learn together, thinking about through the national and local lens, and thinking forward, our hope for the future. So excuse me, I'm going to turn the time over to Corey Feist.
Again, my name is Corey Feist, and it is really an honor and a privilege to be with you today. Hopefully we'll edit out all that other nonsense that you saw me talking and getting nothing. What I was sharing to myself, apparently, was how important it is for me to be here with you at Intermountain today, because I have a deep personal connection to Intermountain. I was basically mentored by my former boss, who was from Intermountain. So I learned a lot about the culture, and I learned a lot about the people. And so being here with you today is really an important thing for me on a personal level. I came up through the ranks first as an attorney and then as an administrator, looking over the medical group at the University of Virginia. I spent 20 years in total at the University of Virginia. And one of the things that was really important to me was to stay connected to the needs of our clinicians. At the University of Virginia, we just have one medical group that services the entire health system. And so staying in constant contact with them is critical. And so when I became the CEO of that medical group a handful of years ago, I went and canvassed my constituents, and I said to the department chairs, what is it that you need? What is it that's important to our clinicians that maybe we've been missing all along. And to a person, everyone talked about the well-being issues. And they didn't always use that term, but they talked about how the joy in medicine had been lost. They talked about the challenges of the electronic medical record and all those sorts of things that get between a clinician and her or his patient. And so we endeavored to start looking at those things at a systemic level within the University of Virginia, changing the way that we evaluated our IT and looking at how we made improvements clinically into the environment. And so it was just completely incredible in some ways that in April of 2020, this very deep personal tragedy that befell our family created this atomic collision, if you will, between my personal and my professional life. And so now I've stepped out of my role at the University of Virginia because this role is so much bigger and taking of my time as the president and co-founder of the Dr. Lorna Breen Heroes Foundation. Our foundation was created in June of 2020, only a handful of months after Lorna died. We're a 501c3 nonprofit, and our mission is to be exclusively dedicated to reducing the burnout of healthcare professionals and safeguarding their well-being and job satisfaction. Envisioning this world where seeking mental health services is universally viewed as a sign of strength for healthcare professionals. So I'm now going to try to share a video here. We'll see if this one works. But here's a little video of our story, and you'll get to meet my wife, Jennifer, and hear a little bit more about the story of how we came to be our foundation. And the audio is not working at all on this. Let's see here. Never had this problem before. So we'll just skip that and keep going, Anne, because that's what we do in COVID times. We just skip and keep going. But let me go back for a second and let me just tell you this story in my words then. So it was March 10th, 2020. It was the last day that Lorna and I skied together in Big Sky, Montana. And she returned from Montana to New York City, where she was the medical director of a very, very busy emergency room. And almost immediately contracted COVID, almost immediately. This was in the opening surge of the pandemic. And so we're now March 10th, and I'm sorry, we're about March 13th, 2020. And between then and April 1st, Lorna tried to recover at home. She was a single 49-year-old, never married, never had children, was exclusively focused to being an amazing physician. And she went back to work her first day without a fever, which was April 1st. And so we spoke to Lorna on April 1st, and she said to us two very important things. One was that what she was seeing was Armageddon. In her entire career working in New York City, she had never seen a scene like she was experiencing, like she'd returned to. Patients dying in waiting rooms, oxygen just expiring while patients were holding temporary oxygen on their laps. And the second message that she gave us, loud and clear, was that she couldn't keep up and that her colleagues could tell she couldn't keep up, and that would impact her career. So instead of stopping because she couldn't keep up, she kept going. She was scheduled for 10, 12-hour shifts in a row, but she wasn't working 12 hours. She was working 15 hours and 18 hours because no one was going home. On April 9th, she called my wife, Jennifer, her closest sibling, and said she was unable to get out of her chair and she wanted to die. Now, this was an individual who was a highly accomplished physician with no prior mental health history. She was getting her MBA because she was trying to advance her career. And she was in a position where she was literally catatonic, because what she had seen, what she observed, and what she'd experienced. And so through a chain of friends and family, we got her to Charlottesville and got her to take care of herself by becoming an inpatient at the University of Virginia Hospital in the psychiatric unit. Her first and only mental health treatment of her entire career. April 11th, she called us from her hospital room and she said, "Now that I have received mental health treatment, I'm going to lose my license to practice medicine and I will never be a doctor again. The one thing I've worked for my entire life." And as both attorneys, we said, that can't be possible. Jennifer's also an attorney. And we said, that's not something you have to worry about. But she said, no, you don't realize I'm going to lose my license to practice medicine. And so Lorna spent about 10 or 11 days as an inpatient in the psych unit. She was doing a lot better, was discharged. And then after only about 5 days at home, she died by suicide on April 26, 2020. Less than 12 hours after Lorna died, the New York Times published her cause of death over our family's objection. We were as burdened by the stigma of suicide as anyone. And we also felt like COVID played a significant role in her mental health. And we wanted others to understand the impact that it could play on theirs. But the New York Times was anxious to publish her cause of death and sensationalize this suicide. And so in the days that followed and the publicity that followed, what also came to us was an outpouring of support from the healthcare community, as well as what I would describe as a cry for help from the medical community. Individuals saying that they had long put off their own mental and overall well-being for those of others, and really sharing how hard it was to be a clinician. And again, remember, this is early days in the pandemic at this point. The pandemic had not scaled to the country as much as it had. So these were all reflections pre-pandemic, which I think is important. So now where are we as a country? And apologies to any non-physicians, but I'm going to share some physician-specific data because I think it's important to just show how far we've come, but also how much more we have to do. For those of you who are not familiar with this Medscape survey of 13,000 physicians, it was published on January 21st of this year, and it asked some important questions. First, it said, which are the physicians who are most burnt out? And you'll see in these little bars that emergency medicine and critical care physicians are really at the very top. And then it goes on to say, well, what contributes most to your burnout? And surprisingly, COVID is on the bottom of this. It's not COVID. It's all the things that we knew before the pandemic were contributing to burnout. Too many bureaucratic tasks, a lack of respect from administrators, employers, and colleagues, too many hours, a loss of control in my life. Those are the things that we need to laser focus on here as we're trying to solve this issue. And then to Lorna's example about why she didn't want mental health treatment. Why have you not sought help for mental health, burnout, or depression? 49% said they can deal with it themselves. But look at the rest of these bars. 43% don't want to risk disclosure to a medical board, just like Lorna didn't. Did I mention, though, that in New York State, where Lorna was practicing, there is no such reporting requirement. There's not even a question on a licensing application in New York. So why did she think this was an issue? Why do many physicians think it's an issue? This is part of what you are trained to hear, is that no matter what, it's going to get reported to your insurance. It's going to get reported to your medical board. And it may, but in some states, in many states, the laws are actually favorable or getting there. And so we need to do a better job letting people know what the current state is. But this, my friends, is a roadmap for some immediate action that we all need to take, and roadmap that we're taking at our foundation. I also want to share a piece of information for those of you in this first camp, which is I can deal with this myself without professional help. And that is that most of you went into healthcare to take care of others. Every health system across this country that I'm aware of is very focused on this thing called quality. Well, the data that we have shows that burnout has been shown to cause a 200% increase in medical errors. I would ask the question, if we were in a place where we could all have a in-person chat, by a show of hands, if you went into an operating room and there was a medical device in that operating room which had a 200% increase in medical error, would you immediately stop using that medical device? My bet is the answer would be yes. We need to think about well-being in this context, both from a system and an individual perspective. So our foundation has really been focusing in three primary areas: awareness, advocacy, and advancing solutions. First, to awareness. We have published this story now, or the story has now been published around the world over 300 times. We've co-authored 11 national publications, including one on physician suicide a year ago in February. I've now done hundreds of panels, podcasts, and my adolescent children are highly underwhelmed by our 6,000 social media followers. So maybe you all can help us with that. But you can see that this conversation we've been having both inside healthcare, but also in national forums, because we feel like it's important for everyone to understand the complexity of this issue, as well as pay attention to it. In addition to our awareness efforts that have been more generally focused, we have had a specific focus on physician suicide. I came to learn after Lorna died, there was this thing called National Physician Suicide Awareness Day. And we help to now advocate for resources and share resources at npsaday.org for organizations to help prevent suicide. After I met Anne in San Francisco, one of our colleagues at the meeting took me aside, because during my talk in San Francisco, I mentioned that Lorna was the first physician to die by suicide during the pandemic, because it was April 26, 2020. But statistically speaking, that's not correct, because what we do know is that physicians die by suicide pre-pandemic, twice the national average. So do nurses. In fact, 400 physicians die by suicide each and every year before the pandemic. We know that number is rising. We know Lorna wasn't the first. She just got the publicity. So one of the things that we've understood about our impact with just awareness is that when the unspeakable happens to you and you speak about it, it gives others permission to speak. And so one of the reasons why we're here today, and I will be beaming in Boston tomorrow and around the world on Wednesday, is that the more we talk about this, the more we have the opportunity to change the culture and make it okay. Because some of this stuff costs money and is super complicated, folks. It's healthcare after all. That's why we got into it. It's almost an impossible problem to solve that we have. Don't worry, we've got some solutions. And some of them are complicated, but some of them are very simple. Some of them are simply looking out for each other, tapping each other on the shoulder, like Lorna needed that day when she went back to work on April 1st, 2020. She needed someone to tap her on the shoulder and say, "You don't look well. You need to go home." Because if that had been the culture in New York on April 1st, 2020, I guarantee you we would never be having this conversation today. So as we do in healthcare, we measure. So let me give you a tangible number. The impact of our awareness has now been over 150 million in this country and growing. But I think more important than that is the anecdotal stories that we're hearing from folks. From the clinicians who say that her story helped push that individual to get help, but not wanting to share still because of fear it will be held against this individual who comes from a very notable health system in this country. Or by the caregivers of our clinicians who have said to us directly, if you've ever wondered about the immediate impact of your work and the importance of sharing her story and the specific conversations, how those conversations have had the ability to be life-saving, and how patients have been saved because mental health professionals have been able to recognize similarities in language around stigma, around reputation. So now to advocacy. As a lawyer, I have to include this in every presentation. But this is where we've also made significant strides in looking at removing barriers and ensuring consistent support at all levels, including our federal level. And here, my friends, we are here to celebrate today an incredible milestone for healthcare, which is that we have the first ever federal law looking out for the well-being of the healthcare workforce. And for those of us in the Feist and Breen family, we are incredibly honored and humbled that this law bears Lorna's name. It will be signed by the President of the United States imminently. It has over 190 co-sponsors. It has over 80 health associations who have endorsed it. And it includes over $140 million of new programmatic funding for health systems, $103 million of which was already allocated through a HRSA grant process. I have the opportunity to turn from these kind of conversations at a system level to my family who's still grieving a loss. This is a quote from Jennifer when she heard that $103 million was given out in her sister's name. So what is the Dr. Lorna Breen Act, soon to be Dr. Lorna Breen Law? Well, first of all, just remember it's first of its kind. I like to point that out because we should have had something like this a long time ago, friends. But it really does four major things. First, it establishes well-being grants for the training of health professional students. Think medical students, residents, fellows, dental students, the like. It establishes a national evidence-based education and awareness campaign that the CDC is about to run that we're heavily involved in. It establishes well-being grants for the current workforce. And it establishes a comprehensive study of the root causes of these issues so that we can iterate on the Lorna Breen Act and grow this law into a more comprehensive law. We know this is the first of its kind, but it's also the first start at a law looking out for the well-being of the workforce. And we'll be actively involved working to evolve this new law to the betterment of the healthcare workforce. In addition to that level of advocacy, we've been working at the state and local level, and this is where you all can also help. On September 9th, we published an article in U.S. News and World Report identifying 6 known barriers to mental health access that is really focused exclusively on doctors and nurses and not lawyers like me and not a lot of people. I'm not sure you all are aware of this, but this is not okay, and it likely violates the Americans with Disabilities Act. So the first 4 are bolded because they are all very similar and that they are questions that appear on applications, whether that's for state licensure, or credentialing in a hospital, or credentialing to be on a panel for a commercial insurance product, or to get malpractice insurance. Those questions ask about your prior mental health history. If a question goes beyond asking about current impairment, it violates the Americans with Disabilities Act, folks. In addition, in some states that don't have safe haven protection, a physician's mental health medical record, their own mental health medical record, can be subpoenaed when that physician is being sued for malpractice. Think about that for just a second. You may or may not have committed malpractice, you're being sued for it. And to put a little extra salt in that wound, the plaintiff is going to subpoena your mental health medical record to see if you've ever been treated for mental health. That doesn't seem right, folks. We need to change these laws. In Virginia, we happen to have a law called the Safe Haven Law, which protects those mental health medical records of the healthcare workforce. We need to make sure they're in every state. And in addition, we need to make sure that the medical plan design, I should say not health plan, it should say medical plan, or I guess it's okay to say health plan. The health plan design of all of our health systems provides for multiple avenues of mental health treatment outside of the medical institution that the provider works. We know of many cases where just the knowledge of mental health treatment can cause either individuals to not get mental health treatment themselves or to do something even more catastrophic. So one of the things that we're advocating, and this is because of the data that we see, is that there are states where and organizations where these barriers do not exist. The workforce needs to know the truth about whether these barriers apply to them or not. Because as I said before, tragically for our family, Lorna thought they applied to her when they did not. And one thing we can do collectively is just simply share this information, as it can be life-saving. One of the things that I like to point out here is the Feist family was huddled around the TV during the last State of the Union. Now, I can't tell you the last time I watched a State of the Union, but the day of the State of the Union, we got this fact sheet from the Biden administration, which we thought meant that we were going to be mentioned, and this law was going to be mentioned in the State of the Union about 2 weeks ago. While it was not, it was included in a briefing and as part of this comprehensive national mental health strategy that the Biden administration is rolling out. Important work that needs to continue. Now, this video won't work, so I'll skip right over it and go to solutions, also being mindful of time because I think I've lost complete track and because I messed up the beginning. But I want to share quickly with you this national initiative that we've also begun called All In Wellbeing First for Healthcare. And we launched it with a consortium that includes nurses and hospitals and pretty much a panacea of healthcare providers here, with two primary goals: advancing solutions to improve the well-being of the healthcare workforce, as well as creating systemic change by identifying and working to eliminate persistent mental health barriers that impact you as a healthcare worker and not me, but those impact public health. We've made great progress in launching this incredible resource, both a financial resource through a fund, as well as a website that's now designed to easily provide access to a community conversation focused on well-being, as well as resources. And I'm going to share a few of those resources with you in just a moment. And here they are. So I was part of a task force that worked on something that sounds like a piece of legislation, but it's called the 2022 Healthcare Workforce Rescue Package, or the Wellbeing 5 for short. These are 5 things that are based on data and that every hospital in this country, we believe, can and should be doing in the next 30 to 60 days. First, adjusting expectations and recognizing that these are non-normal times. My favorite, number 2, getting rid of stupid stuff. Looking at the fact that 70% of a physician's time is spent on administrative tasks. That means you're only spending 30% of your time taking care of patients. Maybe we don't have a workforce problem. Maybe we have the workforce doing the wrong work in this country. 50% of a nurse's time is spent doing administrative tasks. What if we eliminated even half of that administrative burden on our healthcare workforce so they could take care of patients? That would help with number 3, which is get radical to shore up staffing, as well as help us identify a responsible chief. Now, this does not mean we have to create a bunch of positions in health systems for well-being, although I would love that. Not everyone has that kind of a budget. But we believe very strongly that someone needs to own well-being, and that someone needs to have operational authority, because most of this is not anything more than operations 101, my friends. This is about trying to redesign this coal mine, not make our canaries stronger. While it's important to provide therapeutic services to our workforce, what's even more important is to have an environment where they can thrive. And so having a chief well-being executive got that operational authority is one of our top 5. We started with a list of about 50, so I just want to give you a perspective. And then finally, this is a little bit of a radical statement. These are intended to be a little bit of headlines, but employee assistance programs are not enough. Do more. We recognize that EAP programs provide an incredible resource, and many of them are well utilized, but not all. And they tend to vary based on who the workforce is. And so things like peer support programs and other types of non-traditional therapeutic programs need to be explored right now by health systems. As I transition to my final slide, I want to share with you an analogy that I was talking with a group of MBA students who are doctors trying to get out of the practice of medicine just this weekend about. We talked about the concept that before you enter a patient's room, you take care of yourself, and health systems are responsible for taking care of yourself. They give you this thing called PPE, which prior to the pandemic, I had no idea what that was, but you all knew because you're healthcare workers. Thinking about well-being of the workforce as a critical component of PPE is one of the things that I'm advocating for from an attitudinal perspective that we need to change in this country. Every health system needs to recognize that just as it is important for you to don and doss the appropriate physical PPE, you must have the appropriate mental health PPE to be successful if you are to be able to thrive and continue to do all this amazing work that you do every day. So that's it. That's what I had to share with you today. We have stepped into this arena. We didn't do it by choice, but we're here and we're here to stay. Here's my contact information. Please follow us on social media so my children can't make fun of me anymore. But please consider me a resource. And Anne, I want to thank you so much for the opportunity to be with you today. And apologies for the technology issues on the beginning of this, but it's really been a pleasure. And thank you so much. I look forward to this conversation.
Great. Thank you, Corey. I'm going to have you stop sharing your screen and we'll have Katie get back on the slides. You know, as Corey, as I was listening to you and reflecting on all that you and your family have been through and all that we have been through, I thought this would be the right time to take a deep breath, pause for a brief moment to remember and acknowledge those who've passed, our friends, other physicians, APPs, nurses in our world, that we miss them, that we honor them. And the work that we will do going forward will be important and valuable as we step back into our places of work and our places of home. I have done my usual count to 15. And with that, go to the next slide, Katie. As we think about those 5 steps of healthcare and the healthcare workforce rescue package, we have looked at those. We have kind of done an inventory of what we are offering, and it would be neglectful if I didn't say thank you to our team of well-being members who have worked really with a common purpose at Intermountain, our EAP colleagues, our nursing colleagues, physicians and APPs, our operational colleagues, our HR colleagues who've stepped up and said yes. So we are using those 5 steps as a checklist against what we're doing. Mason, I'm going to turn the rest of our time, maybe 10 minutes or so, and then we'll have some time for questions, to talk about what you are working on and how we can start thinking about the future locally.
Great. Thank you so much, Anne. And thank you, Corey, for a wonderful presentation, for all of the work that you're doing to advance this cause for all of us. It's very deeply personal to me, and I'm sure to everyone that's on this call. I thought I would start off my comments by just referencing something that a friend of mine who works in an organization that provides a resiliency-based approach to managing traumatic reactions to various issues throughout the world, whether it's war, torture, refugees, other types of really horrendous traumas. She and I have worked together on a couple of different issues around resiliency with healthcare caregivers in terms of how to move past COVID and some of the issues that we're facing right now. And one of the terms that she has coined is called the gifts of COVID. And I love that term because it really takes something that I think all of us have found to be tremendously personally a negative and really difficult experience to say, look, what are the gifts that we can find from this? Where can we find the resiliency to move past this into the next phase? And one of those gifts is that it's shown a bright light on the issue of caregiver burnout, one that I think and many of us have worked on over the years, and finally to be in a place where this has become front and center is in comments coming from the President of the United States and a law that actually is funding research and promotion of advocacy for this effort is really important to me, and I think is really one of those gifts of COVID that I would just point out. So I do think that there's a lot of hope for the future in terms of how we move forward. Now, specific to our Intermountain caregivers and really where I see us going in the future, there are a couple of pieces that I just really want to point out to you. One of them is that my first day working at Intermountain about 5 months ago, in my new role, I was in a meeting where our CEO, Mark Harrison, looked to our team and said, look, we want you to come up with the strategic plan to double our access to mental health care over the next 3 years. And he said, but before you do that, I want you to focus on what we can do for our caregivers. And it's absolutely coming from our CEO to say, we want you to focus on this. It's a priority. It's coming straight from me to you as one of the top things you need to work on in these next 3 years. And so we've really taken that and we've begun to run with it and try to think about how we can support caregivers, reduce burnout, but also importantly, really facilitate access to mental health care, addictions care for those caregivers that are really suffering due to burnout or for other factors. So one of our major foci of work over the next 3 years, and really in the short term and the immediate term, is going to be to set up systems in our own Intermountain system for our caregivers that can allow them to access care frictionless in as frictionless a way as possible, in a confidential fashion, and really go beyond that EAP. I love that term, Corey. How can we actually go beyond just EAP? Really important, crucial resource, but we can't stop there. We have to think about how we make care easier to access, more frictionless, and how we can make that as confidential and the least stigmatizing way that we possibly can, including those that want to go outside of our system is really, really important. That's been a big focus of our work in the short term to really figure that out and to help caregivers navigate to the appropriate resources. I would also say that we're taking a really hard look, at least in my service line. I know other work is going on in other service lines as well. We're taking a hard look at how we balance the needs of the organization with the needs of our caregivers, because we know that without caregiver wellness, without caregiver well-being, there's no way we can take care of our own patients. And I think that's become something crucially important. Corey, I think about your sister-in-law being there in the ER with probably a board of 18 or 20 patients, recognizing she was on hour 15. I'm a physician. I know exactly what that's like. You think, you know what, I'm just going to push a little harder. I can find it within me to kind of get through this and get these rest of these patients seen because that's what is important. I'm a doctor. It's what I do. We have to really counter that attitude in lots of ways to say you've got to take care of yourself first before you can provide care to a patient. And so I think that type of culture and attitude is one that we want to lead in Intermountain, and we want to figure out a way to make that systematized within our own system. So a large part of our focus in behavioral health, and again, it's other service lines, is going to be really making that happen, really delivering on that commitment and promise to put our caregivers first, and to really look towards their well-being as being primary and of so much more importance in many respects than our patients, because that's really where the care starts. I also want to say we're looking at some innovative well-being programs, digital applications that actually will allow caregivers to access care, promotion of kind of work-life integration, work-life balance, really trying to understand how we can support caregivers in a 360-degree fashion and really provide the support that they need. And if you looked at our strategic plan, if you saw the visuals that accompany it, in all cases, the caregiver focus is the biggest box on that slide. To say, before we can really look at our strategy for how we deliver care, we have to take care of our caregivers. Do we have the answers yet? I'm going to probably look to Corey's organization to help with that to a certain degree. Look to other people that are really studying this, to working with Dr. Pendo and really understanding what some of the issues and the pressures that our caregivers are experiencing to help me figure out a way that we can find solutions within our system. And that's a commitment that I think all of the senior medical directors, all of the people who are in leadership of operations are really making, because we understand that we have to do this now. And COVID has helped us to understand that. I would also just say that I think it's important that we broaden our workforce. It's important that we also consider the impact on nurses, our patient service representatives, those who are really involved in the day-to-day care of individuals, because those individuals are at high risk of burnout as well. And understanding the unique pressures that my patient service representatives on the front line experience versus the physicians is going to be an important part of our work to really understand that and prevent burnout throughout the healthcare system. We know it's not just physicians and nurses. We know that there's a huge turnover in healthcare in general, and a large part of that is burnout. And we need to understand how we can help our caregivers engage more with their jobs, engage more with our patients, but also find the joy and meaning we know that is actually a real antidote to burnout. And the more that we can do that, the more that we can effectively understand how we can help caregivers to move forward and feel that joy and be able to access that in their day-to-day work. So again, an important piece of work that we're working on right now. But I think I just want to encourage those of you who are on this call, and I know there are some of you who are in a position of feeling burned out, feeling frustrated, a lack of compassion, unable to access that joy in life and work that's so important. There is hope and there is help. And it's important that we work to reduce the stigma. It's important that we actually learn how to reach out to you, and that we learn how to make things easy for you to seek care when you need it. Because there is help, there are effective treatments, and there are ways that we can actually move forward together, and there's a brighter future tomorrow. So I just want to close with that, Ann. I think those are the comments that I want to make, and just know this is a big commitment from Intermountain and all of us to help each of you to move forward and find that joy and meaning in your day-to-day work.
Great. Thanks, Mason. I think having that national and local perspective has been really useful. We did have one question from the audience about the priority of a chief well-being officer or well-being executive. Corey, do you want to start? What would you say is their number one priority?
Yeah, so. It's a great question. So first of all, there's an organization that's coming together, which I know Ann is aware of. It's called CHARM, the Collaboration on Healing and Medicine, and they are trying to establish standards for what it means to be a chief wellbeing officer. But right now, I think that the two priorities, if you look at that Wellbeing 5. What I see in that is that 4 of the 5 are operationally focused. The last one is on mental health and I would just say support of the healthcare workforce. So these are individuals that are like COOs of hospitals or health systems, or CEOs of hospitals or health systems, who have the authority to prioritize redesigning this coal mine and bringing the, changing the environment where the healthcare workforce works. I've heard so many times where a physician or a nurse will go and they'll either go to a peer support program or they'll go into EAP, and they'll share concerns about the environment that created something negative, and they'll go to therapy and they'll talk about it, but then they go right back into that same environment that created the issue. And so we've got to have someone who's really focused on how to do that. And I know that that's hard stuff. I mean, that is, it takes a long time to do, but I've got to say we first of all, don't boil the ocean, start small, start with pilot programs, but we've got to start the operational work. And that's where I think that roadmap around Wellbeing 5 is a helpful starting point.
Yeah. I think as, happily Intermountain does have a presence on the CHARM network. So we're able to learn from other health systems and bring to the organization what we're working on, what we're struggling with, how we're solving problems in our day-to-day work, which has been really useful. We are at the time of our grand rounds today. Apologize for the small audio mishap, but am deeply grateful for both Corey and Mason as we talk about the mental well-being of our caregivers. You can see, if you're on the WebEx, you can see the CME code is 20268. If you are not, I'm going to repeat that again, 20268. We will be back next quarter with another well-being series, Thriving in Medicine Today. Until then, I am pleased to sign off. If you've got thoughts, questions, ideas, recommendations, do not hesitate to reach out to me. Always available. Thank you, everyone. Good night.
And it's Paul.
Over to you.
Thank you. I just want to thank you, Ann, for organizing this and keeping this mini series going and the important conversation around this. The only way we're going to get better is to get upstream and to talk about it. And this was just a fantastic conversation today. So thank you. Sticking on one of our main purposes of these grand rounds is keeping us updated on value-based care. And next week, we'll be having a discussion around colorectal screening with Dr. Tay Kim and Dr. Merriman, Dr. Nate Merriman. So with that, we look forward to seeing everybody next week. And thank you again to this great panel.
Thanks, everyone. Good night. Bye, Paul.
Night.
Thank you all.
Bye, Corey. Bye, Mason. Thank you.
Bye-bye.